Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the urinary bladder diverticulum. The normal pressure of the urinary bladder at the starting of micturition is 35 centimeters of water. Hypertrophied trabeculated bladder exerts pressure to pass an obstruction exerts about 100 centimeters of water pressure. This pressure causes the mucous lining between the inner layer of hypertrophied muscle bundle to protrude, so forming multiple saccules. One or more of the saccules is forced through whole thickness of the musculature of bladder wall, forming a diverticulum. Types: congenital diverticulum. It is rare and not important. It is situated in the midline anterosuperiorly, representing unobliterated vesical end of the urethus. It empties with the bladder, hence no symptoms are found. Pulsant diverticulum. The cause may be the contracture of the bladder neck, benign enlargement of prostate, fibrous prostate, urethral stricture and congenital valves of the posterior urethra may cause the condition. It is usually situated above and to the outer side of the ureteric orifice. The size may be 2 to 5 centimeters or larger. The diverticulum enlarges in downward direction and sometimes obstructs the ureter. Clinical features: when not infected, won't cause any symptoms. The majority of cases are males and over 50 years of age. There are no pathognomonic symptoms of vesical diverticulum. They are those of the urinary tract obstruction, recurrent cystitis and pyelonephritis. Hematuria due to cystitis, vesical calculus or neoplasm is the main symptom in third of the cases. In few cases, micturition occurs twice in succession. Second may follow a change in posture. If the first is clear and the second is cloudy, diagnosis is confirmed. In case of chronic retention of urine, two swellings may be found rising out of the pelvis, one being the bladder and the other is the diverticulum. Cystoscopy. Usually the orifice of the diverticulum is seen as clear-cut hole of the diameter of the pencil. The depth of it is black and not illuminated. If the bladder is inadequately distended, the mouth of the diverticulum is seen closed. The mucous membrane around the orifice is thrown into radiating pleats. So, while searching for the diverticulum, it is important to have the bladder fully distended. In fully infected cases, such irrigation is necessary to view the bladder wall clearly. Sometimes it is possible to pass an endoscope into the diverticulum and examine its interior. Excretory pyelography, along with the cystogram, give the information regarding the size of the diverticulum. Retrograde cystography. The bladder is emptied of urine and filled with non-irritating radio-opaque medium. Radiographs taken before and after micturition shows dimensions and position of the diverticulum clearly. Indications of operation. The diverticulum gradually increases in size. If infected, can't be completely cured. It should be removed usually when the association of lower urinary tract obstructive lesion is treated. The operative treatment. Preoperative antibiotic treatment is given. If there is sepsis and retention, indwelling urethral catheter is passed and kept for 48 hours and give bladder washes. If the infection is not controlled by above measures, suprapubic cystotomy is indicated, and then a second tube is passed into the diverticulum and stitched to the orifices so that both cavities can be irrigated. Frequently, suprapubic cystotomy renders subsequent diverticulectomy more difficult. Combined intravesical and extravesical diverticulectomy. Cystoscopy is performed and a large ureteric catheter is passed up the ureter on the affected side and left in place. 8 ounces of lotion remaining in the bladder. With the patient in the Trendelenburg position, the anterior bladder wall is exposed through a suprapubic incision. The peritoneum is dissected upwards, and that side of the bladder bearing the diverticulum is cleared from the surrounding structures with the fingers till some part of the pouch is brought into view. The bladder is then incised in the middle line near its dome and emptied by suction. The interior of the diverticulum is packed with a strip of gauze and with fingers of one hand in the bladder, and recti muscle is retracted widely. The diverticulum is separated from the surrounding structures by gauze and sharp dissection. The neck of the diverticulum can be separated from the ureter, and when the pouch is free, it is severed from its attachment to the bladder by a diathermy knife. The resulting defect is closed in 2 layers. The cystotomy incision is sutured around a Malcott's catheter, and the abdominal wall is closed, leaving a drainage tube in the extravesical space which housed the sac. If the sac is densely adherent, to carry the incision in the bladder down to the rim of the diverticular orifice and detach the diverticulum together with its fibrous rim. The incision in the bladder is closed and the diverticulum left in position with a corrugated drain into it for 3 days. The tract fibroses rapidly after the removal of the drain. Complications. Recurrent cystitis. As the diverticulum can't empty itself, there will be remnant urine within it and get infected. Once infected, it persists and recurs after treatment. The long-standing cases, peridiverticulitis, causes dense adhesions with surrounding structures. Vesical calculus. Due to stagnation and infection, calculus may be formed in bladder or both. On rare conditions, a dumbbell calculus fills the diverticulum and projects into the bladder. Hydronephrosis and hydroureter. Due to compression over the lower end of ureter, it is followed by hydronephrosis and hydroureter. Neoplasm. It is rare, but unless detected early stage, prognosis is poor due to extravesical invasion through the sac. Traction diverticulum of bladder or hernia of the bladder. A portion of the bladder protrudes through the inguinal or femoral hernial orifice. In rare cases, the condition is frequent in femoral and direct inguinal hernia. The disposition of the diverticulum in hernia varies, and in order of frequency they are intraperitoneal, paraperitoneal and extraperitoneal hernia of bladder. Clinical features. To empty the bladder, the patient exerts the pressure on the hernia. It is confirmed by the cystoscopy and cystography. That's all about the urinary diverticulum. And in the next video, I will discuss about some other disease. Thank you.